As you know, in 2014, the International Myeloma Working Group updated the diagnostic criteria for myeloma. And what the International Myeloma Working Group did was to take patients with asymptomatic smoldering myeloma and take a small number of them and upstage them into symptomatic myeloma. That includes patients with more than 60% plasma cells, free light chain ratio more than 100, or more than one focal lesion on MRI. If a patient with smoldering myeloma has any of these, they're automatically now called as having myeloma even without symptoms. But you want to keep in mind that that change in the diagnostic criteria affects very few people with smoldering myeloma. The vast majority of smoldering myeloma is still smoldering myeloma. And we want to figure out who are these people who need treatment, high-risk patients, and who don't need treatment, low-risk patients. In 2018, the Mayo Clinic published the 20-20 criteria, which identifies patients with high-risk smoldering myeloma very easily and enables you to prioritize who is a candidate for clinical trials as well as early therapy. So what happened in the last year was that the International Myeloma Working Group validated these criteria. And this was published in Blood Cancer Journal. And it's important for you to keep in mind. The three risk factors we are talking about are M spike more than 2 grams, free light chain ratio more than 20, and bone marrow plasma cells more than 20%. If a patient has 2 or 3 of these abnormal, they are considered to have high risk smoldering myeloma. This is the group we want to watch out for because they have a 50% chance approximately of progression within 2 years. And this high risk group accounts for about 35% of all patients with smoldering myeloma. This is the group that we want to target. And so this criteria is very useful for you to keep in mind when you see a newly diagnosed patient with smoldering myeloma. Now, the same IMWG also recognized that you may have at your disposal additional factors that can also affect risk, such as you actually know how abnormal the free light chain ratio is. It's not just more than 20, but if it's more than 40, that increases the risk. Similarly, if the M spike is more than 3, that increases the risk. Bone marrow plasma cells more than 40%, or FISH abnormalities like deletion 17p, they increase the risk. So if you put all of this together, you get a scoring system, which is very easy to calculate. And patients with a high score can have a risk of progression almost approaching that of what we consider now as myeloma. And so this scoring system, if available to you, would be also useful in making decisions in addition to the 20-20 system. So keep these two scoring systems in mind, the 20-20 staging, as well as the IMWG risk score. Now, why is this important? What happens when you have a patient with smoldering that you consider as having a high risk smoldering? We now have data from randomized trials that if you take high-risk patients with smoldering myeloma, early intervention can delay progression to end organ damage. And here in the Spanish study, it also led to improvement in overall survival. So overall survival was better in patients getting lenalidomide and dexamethasone versus observation in patients with high-risk smoldering myeloma. Now, in the last year, the Eastern Cooperative Oncology Group, Dr. Loniel published in Journal of Clinical Oncology the results of the ECOG lenalidomide versus observation smoldering myeloma trial. And in this trial, you can see that early therapy with lenalidomide was associated with a significant improvement in progression-free survival. And progression-free survival in this trial was progression to end organ damage, such as lytic lesions or renal failure, not like myeloma progression with just a rise in the M spike. So this is real progression, and real progression was prevented by just using lenalidomide alone, single agent. And if you look at the high-risk group, the 20-20 group, that difference was even more striking, almost a 90% reduction in progression if you had lenalidomide therapy. So based on these two important points that we now know which patients with smoldering myeloma we need to target. We simply use the IMWG system, the Mayo 2018, and classify patients into high risk versus low risk. And then if you do classify somebody as high risk, we can give early therapy with lenalidomide or lenalidomide dexamethasone. And so here's my algorithm now for 2021. If a patient has suspected myeloma or smoldering myeloma, you clearly have to evaluate them carefully. And if they have myeloma defining events, anything that meets the criteria for myeloma, there's really no question we treat them as myeloma. On the other hand, if they have no myeloma defining events and you consider them as having smoldering myeloma, you use the 20-20 system to classify them into high risk versus low risk. If they have high risk, you know they're going to have a progression risk of 50% in 2 years. And in those patients, our recommendation is early therapy with lenalidomide or Lendex, or offer them a clinical trial. On the other hand, if they have intermediate or low risk smoldering myeloma, then observation is really still the standard of care. Now, you may question, when patients have high risk smoldering myeloma, should they be treated with just Lendex, or should we just give them myeloma-like treatment? And that's an important question because we really don't know the answer. No one's done a randomized trial of that. But thank God we have a trial going on right now. This is being conducted by the Eastern Cooperative Oncology Group, along with other groups, SWOG Alliance. And this looks at Dara-Lendex versus Lendex. And this trial is accruing right now, and it's looking at an overall survival benefit between Dara-Lendex and Lendex. So if you have a patient with high-risk smoldering myeloma, you should certainly consider this trial as high priority.